Hello and welcome to Conversations with Dr. Bachner. I'm so excited to be joined by Carlos del Rio today. Carlos is the other half of the Preeti Milani, the Milani del Rio authorship group that has offered up three viewpoints for us. Carlos is a professor at the Emory Vaccine Center, Hubert Department of Global Health, Rollins School of Public Health. Also a member of the Department of Medicine Division of Infectious Diseases, and has been an extraordinary contributor both to JAMA and to the infectious disease community over many, many years. Carlos, thanks for joining us today.
Happy to be with you, Howard.
So I want our listeners to know I've already sent Carlos a list of really common questions that I get all the time. And so we're going to walk through them, and we're going to play out some scenarios because I think they've gotten very, very confusing for people. So, Carlos, let's first start with what people mean by the incubation period. Currently, the recommendation or the suggestion is that the incubation period for COVID-19 is 14 days. Some have argued it should be 21 days. But can you talk about what the incubation period means?
Yeah, I think we're pretty sure that incubation is the time between when you get exposed to the virus and when you develop symptoms. And it tends to be, or when you have active infection, and it tends to be, we think, somewhere between 2 and 14 days. There may be a little bit of a tail past 14, but it's highly, highly unusual. I think I can very confidently say 14 days feels, about right in about close to 98, 99% of people. The problem we have with this virus is that there's a significant percent of people who are asymptomatic or could have very mild symptoms. So incubation becomes a complicated topic, right? Because you can be exposed to this virus, get infected, develop infection, but don't have symptoms. So you, in fact, will be able to shed virus and transmit the infection, yet don't have symptoms. And that, I think, is one of the hardest challenges with this virus compared to Ebola, for example, compared to smallpox. Those were diseases in which, you could tell when somebody was infected, and not only that, they didn't transmit until they were clinically ill.
Now, Carlos, if I walk around and I'm exposed to someone, and let's say I'm an adult, we'll get to children and asymptomatic disease, which is a little more confusing, and I'm going to develop symptoms. You said I will develop symptoms generally within those 14 days. How soon after I'm exposed and I have disease, am I infectious?
So there are a couple of things. Once you've been exposed, then it takes you a few days for the virus to sort of begin reproducing, multiplying in your cells, and then you have to produce enough virus to then start producing virus and start transmitting. We think that people start transmitting virus. If you think about somebody who's going to be symptomatic, they start transmitting virus about 48 to 72 hours before they develop symptoms. And that CDC has given this very nice term of pre-symptomatic transmission. And that pre-symptomatic transmission is the reason why we recommend that everybody wears a mask. Because I could be sitting here looking fine and in 1 or 2 days develop symptoms and I'm infectious today. Now, there's a percentage of people, not that many, maybe about 3 to 5%, who remain truly asymptomatic. But that truly asymptomatic is a very small percentage of people. I think you were getting to also something there, Howard, that I think is very important. You said I walk by and I get infected. We now know that it's just not, you don't get infected by just walking by somebody, unless, of course, that person kind of like sneezes or coughs right in your face. You need significant contact with an individual, and maybe as long as 10 to 15 minutes, and you need to be in a fairly close space. So that's why we learned from colleagues in Italy, in New York, and other places in China, that a lot of transmission occurs within households. And if you live in a small apartment in New York with a lot of people, if you are, why are minorities so heavily impacted? Because many of them live in very small places where, one is infected and you have, 6 or 7 people living in a 2-bedroom apartment, everybody else is going to get infected. They're close by, they live in a small quarters, and they're frequently together.
Carlos, there's going to be lots of questions, but I want to go through a few more before we get to the questions. So you're infected, you get well. Then when can you visit people, return to work? I mean, the CDC has 2 scenarios, testing and not testing. And they talk about this 10-day period from the time you were well, then that you could return to work or see other people. What's this 10-day rule?
So a couple of things. The CDC has two scenarios of, two negative tests.
Right.
I would tell you that all of us in healthcare are not following those recommendations. We simply don't have enough tests to do that. What we tell an infected healthcare worker is you've been infected, you go home, and then we will see you. You can come back 10 days after your positive test or 72 hours after you've been for 72 hours without acetaminophen or anything, totally asymptomatic, whichever is longer. And it maybe that after 10 days you still don't feel well and you still have a little bit of fever, we don't want you back. So it's either 10 days or 72 hours, whatever is longer.
Okay. All righty. Now let's get to the asymptomatic group, which has really been confusing. And I've said before on some of the live streams, JAMA and one or two other journals published articles early on in February about asymptomatic spread. And in hindsight, it would have been better had we paid more attention to them, because I think they really are the key articles that mandate masking. In any case, what percent of individuals who are infected are truly asymptomatic, not just this pre-symptomatic phase? And is it more common in children or adults, or do we just not know?
It's a pretty small number of people, as I said, maybe 3 to 5%, and we think it tends to be a lot more frequent in younger individuals. So children, young adults tend to have that totally asymptomatic phase. And even, young adults may have a very mildly symptomatic stage. I have somebody that I know right now who is a fairly young adult who got infected. We know he's infected, his PCR positive. His only symptom was fever for a day. And then the only other symptom that persists is loss of smell. That's it. He got fever for literally one day. So, you could have easily passed it as nothing happened, but it was that incredible index of suspicion saying, hey, well, fever and losing a smell, that means you got COVID, that got that person tested, and we know that person is infected, and therefore that person has self-isolated and control, spreading to others.
And looping back to the previous question, when can that person go back to work? So he or she had a fever, lasted 24 hours, and is now well. When can that person return to work?
So 10 days after that PCR or 72 hours after resolution of symptoms. This person could later on develop, fever again or cough or any other symptoms, and then that's what we need to monitor.
Great. Okay. Let's go through some of the issues that have come up more recently, either on the front page of newspapers across my desk as opinion pieces or research. Increasing interest in the role of vitamin D.
Vitamin D is fascinating. I've even dabbled a little bit into vitamin D, was part of a clinical trial looking at supplementing with vitamin D treatment of tuberculosis, because as you know, there's some literature suggesting that people with vitamin D deficiency tend to have more severe and respond less to therapy. Well, absolutely no difference. So there's a lot of diseases and that you go through a literature that there's association with low vitamin D levels, but there's almost no evidence that correcting the vitamin D levels improves the outcomes. And I think with COVID it's exactly the same. I think that you will find studies saying, oh yeah, people with COVID are more likely to have low vitamin D, but that doesn't mean that if you give them vitamin D, now they're going to be better from COVID. That randomized, and again, I go back to the point that at the end of the day, I like to see randomized clinical trials that show, the association does not mean causation.
Remdesivir, some positive results, some not positive results. In the best of worlds, it may reduce mortality by 3, 4, 5%. Still good. You certainly feel good if you're in the 3 or 4 or 5%. But if it's 100,000 deaths and it takes it down to 95,000 deaths, we still have a long way to go. Is it the right drug in all people? Are we giving it too late? Do we need combination therapy? Do you have a feel for that? I know you've been taking care of patients with COVID-19, so you must have a sense of that.
So I will say that I've also been part of the Act 1 and Act 2 studies, so I've been involved in the randomized clinical trials. I would say that today I'm pretty convinced, and we did this in Act 2. We made both arms receive remdesivir, and one of the arms received baricitinib and the other one placebo, but both arms are getting remdesivir. If I was going to get infected with COVID today and get hospitalized, in other words, need oxygen, I would want remdesivir. It is without doubt the only drug that has shown any effect at all as of today. No other drug has shown any effect. That's the only drug that has a signal. Is it a home run? No, it's probably a solid single, but, we still have a ways to go. But I feel, I'm old enough to remember the early days of ACT therapy. I mean, this feels like ACT, it gave a signal. It was the beginning of antiretroviral therapy, but it wasn't the end. Nowadays we're not using ACT. We're using very different drugs. We're using them in combination. So I think it's the beginning, but certainly not the answer. I think maybe in a year or so, we're going to be using combination therapies. We clearly need something we can give orally. Remdesivir is just IV. I understand that the company is working on an aerosolized form of Remdesivir. There's a drug being developed that was developed by investigators here at Emory that is, it's an oral drug, EMDD 2801, that is now in phase 1 clinical trials in England. So I think we're beginning to see better drugs and other drugs, but we need something orally. We need something we can get. Right now, there's nothing you can give to outpatients. There's literally no effective therapy. And hydroxychloroquine is being looked at in a randomized control trial in the outpatient setting. I think we desperately need more drugs. Remdesivir is like the only thing that works, and it's only in very few group of patients. If you look at the Remdesivir data, once you got ICU care, once you were intubated, once you got ECMO, it really made no difference.
So that's consistent. JAMA published a paper last week about convalescent plasma, which has been given to thousands of people in the United States. We published a small trial from China, had to end early because they didn't have sufficient number of patients. And the story was similar to what you just mentioned. It did not work very well in critically ill patients, but it worked better in seriously ill patients. Do you have a sense about convalescent plasma, and have you used it at Emory at all?
I have not used it at Emory. I have some colleagues at Emory that are looking at convalescent plasma. I did review your article and actually wrote a summary of it for Journal Watch Infectious Disease, in which I'm an editor, and I love that paper. I think it's a really interesting study. And again, what a good news to have to stop a trial because you didn't have enough patients. I wish I could say the same thing, right? But the reality is that we need randomized clinical data. And I think that study showed something very important, is that we maybe need to use convalescent therapy even earlier. And I think there's some really interesting thoughts about using convalescent therapy in prevention. For example, if you got somebody who's been heavily exposed, like in a nursing home, would convalescent therapy, convalescent plasma make a difference in that setting? We're also beginning trials with monoclonal antibodies in those settings. So I think that convalescent therapy is a really interesting approach. It may not be the answer. Maybe it's going to be monoclonal antibodies that actually give you a higher dose of that antibody present in the convalescent plasma. What I like in the Chinese study was also that they tested the plasma and made sure that they had antibodies against the binding domain of the spike protein, and they only used plasma that had a titer of greater than 1 to 6 to I think it was 640. So again, they really looked. Not all convalescent plasma is the same, and they made sure they really were using plasma that had good levels of neutralizing antibody.
Now, Carlos, along with 2 dozen other people, you're one of the country's experts in vaccines. I had a chance of talking to Tony Fauci and Paul Offit last week. They said the same thing about vaccines, which I found very encouraging. 3 or 4 major trials will be launched in the coming months. Projected numbers 30,000. Both said that one of the critical issues will be whether or not people in the control group are exposed to disease. Otherwise, it will be very hard to assess efficacy. Are you optimistic about a vaccine, Carlos?
I have to be optimistic. I have to be hopeful, but I also have to be realistic. First of all, developing effective vaccines that prevent infections with respiratory viruses has been exceedingly difficult. I mean, we talk about the flu vaccine has an efficacy of 40%. I mean, it's a crappy vaccine. But if we get 40% efficacy out of this vaccine, we're going to be jumping. We're going to say this is great. The reality is a lot of people say maybe we're going to get 30% at best. But we are hoping that the vaccine is going to be able to also prevent disease, prevent severe disease. So maybe you'll get infected, but you won't transmit or you won't get disease. Now, there are 2 things that worry me. Number one, most of the vaccines we're looking at are using platforms that, while very, very modern, have never been used in a vaccine that we have approved. mRNA, adenovirus vectors. In other words, DNA. They're vaccines that are very high tech, but none of them has proven to go all the way to an approval of a vaccine we're using. Number 2 is that doing a vaccine trial in the midst of a pandemic is exceedingly hard. You're chasing the virus. And the reality is we in public health, you're chasing the outbreak, and we in public health are trying to stop it. So, I feel like a little bit like if you were a surfer, you're trying to find that great wave, but by the time you get there, the wave may be gone. So how do you predict not where the vaccine is, not where the outbreak is right now, but where the outbreak is going to be, so you can actually be there before it starts? Because otherwise, as we're trying to stop transmission, you may get to a point that you say, oh, we now are testing the vaccine, but we can't show efficacy because there's not enough endpoints. And I think that's going to be what, the rush to get the clinical trials started in the next few weeks is because we really don't want to miss that opportunity to test a vaccine. Now, it may be that we actually have to move to South America. I mean, the situation right now in Brazil, in Argentina, and Chile, and Peru, and Mexico is very concerning. And maybe that's where we need to be doing the vaccine trial.
Yeah, I sent you an email this morning. I mentioned I really did want to talk about low and middle income countries. And, I sometimes worry that we don't talk very much about Central and South America. I know you have many contacts. You're a globalist. Could you talk a little bit about what your sense is of what's happening in the various Latin American countries? I know you can't talk about all of them, but do you have a sense of what's going on?
Well, I think what's happening is what we've seen in many other countries, including ours, which is just this virus. This virus hits you like a, punch in the face. I mean, we thought we were all prepared and we had all this great pandemic preparedness plans, and boy, we were grossly unprepared. Imagine this countries that, I was talking to colleagues in Mexico. They're having trouble buying tests. They call the people at Cepheid and they were told, we'll get you tests in 2021. Even if you had the resources, buying tests is not easy. And then you have all the issues of, think about a city like Mexico City, or Sao Paulo, Brazil, 20 million people crowding, a lot of people living in shanty towns and inner cities. A lot of people, the metro in Mexico City transports 5 million people a day. I mean, it's a perfect setting for spread of a virus like this one. So I am very concerned about cities in low and middle income countries. I think that I really worry that simply they don't have the bed capacity that we have. I was hearing, again, talking to about Mexico because I know Mexico the most. I mean, Mexico, the entire country has no more than close to 4,000 ICU beds in the entire country of 20 million, 130 million people. I mean, that is a really, really small number. So the reality is that they're in serious trouble, and we have to realize that it's going to take a lot of leadership and a lot of will, and the population are very scared, and mortality is going up. So I'm very concerned. And again, this is a global epidemic. We cannot be just focused on ourselves. We cannot just say, oh, it's okay in the United States. We're not going to worry about the rest of the world, because we learned that start in China and we said it didn't matter. It's not going to get here. And all of a sudden we got the highest number of cases in the world. But right now you have U.S. as number 1, Brazil is number 2, and Russia is number 3. I mean, who would have imagined that was going to be the order, 3 months ago?
Carlos, I watch the data in the U.S. like many other people do. There's a lot of different tracking services, and some rank the different states red, orange, and green. The U.S. had been having about 20,000 new cases a day for almost 2 weeks plus. And then over the weekend, it went to 23,000, I think, then 27,000. I think the report for today is about to come out. Varying now. I mean, at the height of when the concern was New York and Connecticut, it was 30 or 35,000 a day, and a very focused in 3 states. So that was very, very different. Do you have a sense of what's going on in the U.S., or is it so variable from state to state, it's hard to make an overall comment about the U.S.?
Well, that's absolutely right. I think the U.S. is a patchwork of states, right? It's almost like talking about Europe. You have multiple countries. Every state is a country. And, we're seeing New York cases have really gone down. But at the same time, in California and Texas, Florida, Tennessee, cases are really going up. So it's a patchwork of different places. I think you really have to dig down to the local level to understand the epidemiology, to understand what's happening. Now, I'm not surprised cases are going to go up. I mean, we decided to relax all restrictions in this country. What I wish we had followed the relaxing of restrictions. And I would say, CDC director and CDC has said that, the virus is still here. You need to wear masks when you're in public places. You need to social distance. But somehow a large percentage of the population has pretty much said, oh, I'm done with this. I'm resuming my life. I'm very concerned that, the other day I was driving around Midtown Atlanta and restaurants were packed and people who are not wearing masks. And you're like, okay, people, I mean, have you been not listening to what's going on? And, 20,000, 25,000 new infections per day, new diagnoses per day, and over 1,000 deaths per day. It's not a small number. I mean, we need to realize that this is still a significant epidemic, and we need to convince people that it's not the right time to just say, I'm done with this.
Carlos, if we hover somewhere around 20 or 25,000 cases and they're spread out, I don't think the ICUs will get overwhelmed. At least I hope not. And then we get through the summer, and then we have the issue of 55 million children in school in the fall. We know that 35 to 50% of the deaths are in nursing homes. We know flu arrives in November. I'm painting the picture of what the fall will bring. What are the bridge treatments? Is it monoclonal antibodies? Is it hyperimmune immunoglobulin? Is it convalescent plasma given earlier? What are the bridges, assuming that we do not have a successful vaccine in the fall, which I don't think anyone anticipates?
Well, so I think there's several things. I think number one is that, yes, we need to try to limit transmission, but limit disease among those highly vulnerable populations as much as we can. I mean, we need to remember that in this country, 80% of cases have been in people under 65, yet 80% of deaths have been in people over 65. We really need to protect the older population. I think that the places to be laser focused on in prevention right now are nursing homes, are the meatpacking industry, and are jails, and is in people who live in the inner city, who live in crowded conditions. We really need to focus on those individuals and try to, as much as we can, to diagnose cases, but to stop transmission. I mean, if we can have testing in such a way that you pick up cases, but then you rapidly intervene, isolate, and prevent outbreaks, I think we're in good shape. You don't want a nursing home to have everybody infected. You want a nursing home in which you picked up a case, you tested all the residents, you tested the staff, and you were rapidly able to control the outbreak. I think if we do that, we're going to be okay. And then we're going to have to rely on, monoclonals, hyperimmune globulin, convalescent plasma, remdesivir, a combination of these things to really try to control as much as we can mortality. And then I think we'll get to the fall, and boy, we're going to need to be sure that, first of all, let's hope that this flu season is not as bad as the past one. Let's hope the vaccine uptake is higher than it has been in the past. And let's just hope that the vaccine trials give us some sort of signal. Now, I will tell you that, public health is politics, and politics, as you've seen in this epidemic, like nowhere before, has influenced public health. And I would tell you that I would almost give you in writing that there's going to be a surprise, like 2 weeks before the election, we will hear there's an effective vaccine. There's somebody who needs to be reelected who will rely on saying, I got your vaccine. And it may be, I don't know what they're going to do with the data, but I'm really concerned that we may have a not very effective vaccine, which is going to be touted like the success of the world and is going to be used as a political tool. So I think we in science need to stay focused, and we need to stay true to the science and the data and not be swayed by what I worry about, maybe political manipulations.
Yeah, I have faith that the scientific community will stand up and talk about efficacy and safety. Safety will be the other major issue. We have people who are hesitant about vaccines. I'm not talking about the people who just disregard them or don't believe in them at all, but I'm a pediatrician, and I am worried about the 20 or 25% of people who are just hesitant about vaccines. So I do think the scientific community will really have to provide as much precise information as possible and be truthful with what we know and don't know, and then people can make good decisions.
I agree with you.
One last question before I get to all of the questions. Carlos, is there a way schools can reopen?
It's a really good question. I think we're increasingly realizing that there may be a way, but it may not be schools like it used to be before. In other words, we're not going to go back to normal. We're going to be going forward to a new normal, as Rochelle and I wrote in our viewpoint for you.
Right.
Is we need to think about what is the new normal going to look like, and the new normal is not going to be the old normal. We're going to have this bridge normal in which maybe schools are going to have shifts and maybe continue to do a mix of online and live education. and maybe be able to monitor symptoms closely. And, in some communities that there's very little disease, you can go back to normal. So again, I don't think you can make recommendations for the entire country. I really think communities are going to have to look community by community, looking at their epidemiology, looking at their cases. Even, in a city like Atlanta, I can tell you there's some communities, some areas, some zip codes that I think are going to be fine opening, while there's some other zip codes that I'll be more concerned about. And I think public health is really going to have to practice, we get enamored with precision medicine. I think we're going to have to practice precision public health, right? We're going to have to use data to really focus what we do. And with good data, we may be able to go back to schools. I think opening schools is going to be critical. If you don't open schools, people cannot go to work. I mean, it's very hard to talk about, parents going to work if schools if the kids are still home.
Yeah, we've had one or two viewpoints about the issue, in part because people are now talking about this COVID slide. It's 55 million children between 2 and 3 years of age and 18 who are in school, and what the consequences would be, and if we are forced to keep so many children home from school. There's so many services that are provided, and as you said, many parents can't work if their children can't go to school. It's already disrupted summer and summer plans, and I do hope that we can sort this out for the fall. So some questions. Cloth masks versus surgical masks. Which one is better?
Well, it depends on the cloth mask. I think surgical masks tend to be better because they're uniformly made. I think cloth mask, I've seen some very thin cloths that, I can put my hand on the other side and literally feel the air coming out. And I've seen other cloth masks that have 2 or 3, 2 or 3 layers that are very good at protecting. We got to remember that either it's a cloth mask or a procedure mask. The idea of using that, I think about a surgeon. You put it to prevent your mouth germs to going into the patient. So it's to keep you from infecting others. It's not to keep others from infecting you. So a good test that I tell people is put your mask on, then put your hand about a couple inches away and then blow. And if you can feel the air hitting your hand, it's probably not a good mask.
Great. Can people get reinfected? This comes up all of the time. What's your sense of it? I mean,
my sense is it can happen, but it's rare. I think the great majority of people that get infected, even those that are asymptomatic, there's some really nice data from the USS Roosevelt. Even the soldiers that had very little symptoms, but who clearly had evidence of infection, seroconverted. 92% of them seroconverted and developed neutralizing antibodies. Now, there's 8% of them that did not. So I guess those 8% can probably get reinfected. So I would say it's the exception rather than the rule.
But over 90% are developing neutralizing antibodies, generally as IgG. I know there's IgA may provide some form of protection, but it's largely IgM then IgG, with IgG being most of the neutralizing antibodies, correct?
The question, like another coronavirus, is we don't know how long those would last. Is it going to be 6 months, a year? I don't think there's going to be long-lasting immunity to the coronavirus based on what we know from prior infections.
So, the Remdesivir studies have been published. We published, a study observational that said hydroxychloroquine was not effective. It's not the only journal. Other journals have published the same observational studies. But the issue of zinc in hydroxychloroquine has come up. Do you have a sense of zinc could really change the effectiveness of hydroxychloroquine?
I'm really not sure. I mean, I think what we desperately need in hydroxychloroquine is a well-controlled, randomized clinical trial. I mean, unfortunately, all the studies out there are not what I would call the kind of evidence that I would like to see to say, okay, this works or this doesn't work. And that's why good designed clinical trials are really critical. And the reality is a lot of the decisions that we're currently making are based on not what I call evidence-based medicine, but it's like feel good kind of medicine. I want to do something and I think this works, and it's very much based on case reports. So it's hard for me to know. I think hydroxychloroquine still we need to have the kind of data that once and for all says this works or this doesn't work.
I think it was a reasonable question to be asked within a clinical trial.
Correct.
And I do appreciate that, if you're taking care of someone who's critically ill, you'd like to do everything you can. To the extent that we can try to continue to keep people within randomized clinical trials, we can get answers to the question. Otherwise, I fear we'll get to the fall and we still have not answered the question around numerous drugs, just not not just chloroquine, but there'll be other drugs that we still can't answer the question, is it worth using or not?
And that's so true. And that's why, again, I'm a big proponent that we have to do well-done randomized clinical trials, because that's how you develop evidence. And if you see, the NIH just recently, last week, updated the NIH treatment guidelines for coronavirus. And again, they emphasize that hydroxychloroquine should only be used within the context of a clinical trial.
What is the possibility of people developing antibodies to COVID-19 due to infections with other viruses in the family of coronaviruses?
Highly unlikely. They are different enough. I think if you were infected with SARS, you probably have some level of immunity. But, at best, we had, 9,000 cases of SARS around the world. So there are not that many people out there that had SARS. But if you happen to be one of those, you probably are immune to this virus. I would almost bet you, because they're so closely related.
BCG, and there were some early reports that countries that had high levels of use of BCG had lower amounts of disease. And I said, well, just wait. Let's see what early in the pandemic, you can't really make any of those assessments. You need to wait until there's exposure within those countries. So any sense of BCG and coronavirus?
I don't think it makes a difference. It reminds me, many years ago, I wish I could pull the abstract, but many years ago in one of the international AIDS conferences, I think at 93 or 94 in Yokohama, they presented data from India saying that BCG protected from HIV because there were no cases in India. And I said the same thing, just you wait and look at India right now, right? So I think we need to be careful about those epidemiological associations that really don't really mean much. And, I've seen so many of those come up with this disease. I mean, most recently, I saw one that said that, postmenopausal women were less likely to be infected, and therefore, estrogen was somehow, lack of estrogen was somehow protected. And, come on. I mean, we really need to do, that's why good epidemiology is critically important. Just like randomized clinical trials, we really need good epidemiologists to be doing those studies and not just simply people doing associations. I don't do very much looking back or hindsight. We know we had testing problems in this country. We know we've had troubles with masks. We know we struggled with a very consistent message. Carlos, we have 325 million people in the United States, many with different views of risk and different views of how government should influence their lives. I do think we lost the message around the need for masking and social distancing. Can we get it back, Carlos, or is it just lost? That's a really good question. I think that one of the things that, crisis communication is so hard because also, you're kind of building the boat as you're sailing. During the anthrax attack, Jeff Copeland said something to me. He said, I wish we had known yesterday what we know today. It's so hard to do that, but you need to be communicating effectively, promptly, and be able to say, look, this is what I'm telling you today is based on what we know today, which may be very different from what we know later on. I mean, at the beginning, we were telling people, masks should only be for medical personnel. Part of that was we have done a lot based on scarcity, right? Instead of saying, look, everybody should wear a mask, but for now being, we only going to reserve them to hospitals because we don't have enough masks. We, instead of saying that, we said, oh, no, masks should just be for the hospitals. So I think our messaging wasn't developed the right way. And then as more evidence came along, then we started trying to shift our message. And we weren't good enough at communicating that the evidence now supported this, that, and the other. I hope that we can get back to people understanding the importance of masking. Masking, to me, there was a recent mathematical study from Imperial College saying that if 50% or more of the population use masks, we can bring the R naught down to less than 1. That to me is like, guys, we got a vaccine. But then again, I've been working in HIV for way too many years. And, same thing. Why can't we get people to wear condoms, right? If we had been using condoms, we wouldn't be chasing a vaccine right now. So again, changing behavior is incredibly hard. And there's a component of masking that has to do with behavior. Now, masks are useful for not only preventing transmission. I tell people, if I'm wearing a mask and you see me with a mask, it's also a reminder that something's still out there. And if you see me with a mask, it's just saying, hey, coronavirus has not gone away. And it will also allow you to start thinking about social distancing. I'm about to give you a hand or give you a hug. I see you wearing a mask. I'm going to step back. So I think there's also a component of a mask that I think goes beyond just the virus protection. And therefore, I really think we need to get masks to be back in vogue. I mean, somehow we need to get all our people that are trendsetters to be using masks with, nice designs and nice things, because if you make it fashionable, I think young people are going to be more likely to wear a mask and to think this is a really cool thing to do. And we got to get that.
It's interesting. I got on the elevator with someone. I was walking home, and there's an elevator between two levels of where I live. And it's a short ride. And when I got on the elevator, I always wear a mask inside. When I'm outside, I have to say I usually wear a mask, but if no one's near me, I may take it off. Inside, I always wear a mask. And I went to get in the elevator. This woman was already on the elevator, and she said, well, I'd appreciate it if you don't get on because I don't want to get infected. But she wasn't wearing a mask. And I didn't know if there was elevator etiquette, but I didn't know what to say to her, to say, look, I'm protecting you, but you don't have a mask on. You're not protecting me at all. And it is so much about behavior to try to recreate that notion that wearing a mask needs to be the norm, particularly in closed environments or even outside when you're near people.
So the other day I was getting on the elevator in the hospital, same thing, I was wearing a mask, but somebody was getting on the elevator without a mask. And I literally said to that person, look, if you're not wearing a mask, then I need to get off the elevator, right? Because I think what you said is absolutely right. You were wearing a mask because you were protecting that person, but that person not wearing a mask means that person wasn't protecting you. And we need to get that message across. Wearing a mask is not about me. It's about you. It's about how can I prevent this from getting to others. And therefore, I'm hoping to get people to understand that this is about community. If you care about community, if you care about where you live, if you care about your fellow citizens, wear a mask. I mean, it's a really simple message.
And the other thing is there's almost no side effects from wearing it. There's not many medical interventions where we don't have to worry that we could potentially be doing harm.
Right. I mean, you can talk about, there is a couple of people say, well, if I wear a mask, I'm asthmatic, I'm worried about it. But again, I remind people, my colleague surgeons are wearing masks all damn day and they're working just fine. And they, you get used to it. It doesn't take that long to get used to it, to make it part of your standard. And look at countries in Asia. I mean, many countries in Asia have been wearing masks in the population level for decades, and they do it just fine. It becomes the norm. It's almost like wearing a seatbelt, right? I mean, nowadays, nobody thinks about it. You get in a car, you put a seatbelt on.
This is Howard Bachner, and it's been Conversations with Dr. Bachner. I am so pleased. Carlos has written quite a bit for JAMA in the last couple months. He's a Hubert Professor and Chair of the Hubert Department of Global Health at Rollins School of Public Health of Emory, one of the world's leaders in global health vaccine development, and just gives really practical information. Carlos, thanks so much for joining me today.
It's been really a pleasure, Howard.
I'll have you back in a few more weeks and we can take it up again.
Sounds good to me.
Stay healthy.
Thank you so much. Same to you.
Bye, Carlos.
Bye.